Ladies and gentlemen, thank you for joining Impro Tobacco Cessation Counseling Conference Call. Your host, Melissa Ottinger, will begin.
Good afternoon, and welcome to today's webinar presented by Impro. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you would like to learn more, please visit cancercontrol.impro.org. My name is Melissa Ottinger, and I am a Senior Clinical Quality Consultant for Impro. Today we'll be discussing tobacco cessation billing. So just a disclaimer that the information is intended as a general reference, and you are ultimately responsible for the submission of accurate claims and any type of audit that may occur. So just some facts about tobacco. We know that patients who smoke have an increased risk of developing coronary heart disease, stroke, lung cancer, chronic obstructive pulmonary disease, and those patients who also use smokeless tobacco also have an increased risk of diseases and cancers of the mouth and pancreas, as well as heart disease and stroke. So for billing tobacco cessation counseling, there are two codes that can be used. The CPT code for cessation counseling for patients who are currently experiencing symptoms of adverse tobacco use would be 99406 if the visit or the conversation was anywhere between 3 minutes up to 10 minutes, and 99407 for counseling that lasted more than 10 minutes. The HCPCS code for tobacco cessation counseling for asymptomatic individuals, those not experiencing any adverse events from tobacco use, would use G0436 for counseling lasting between 3 to 10 minutes, which is also considered an intermediate counseling service, or the G0437, which is a counseling that lasted greater than 10 minutes or considered an intensive counseling session. For the HCPCS code, you do use this in addition to the E&M code, as well on the CPC coding, you also use the E&M code with the modifier 25 to identify a separate reimbursable service. The ICD-10 code for symptomatic individuals would be any one of the numerous codes relating to nicotine dependence or a personal history of nicotine use. I've put on two of them as an example, but the list is long, and if you have one that you like to use, feel free to do that. If your patient is having symptoms relating to tobacco use, you would also include the appropriate diagnosis in addition to the nicotine dependence code. So if your patient is coming in for a chronic cough, you would use the chronic cough diagnosis code as well as the nicotine dependence code. And these slides will be available after the call, and we're going to have an opportunity for question and answer at the end. So one thing that's important when you're billing these codes or any codes is your documentation. Every visit where the counseling code is used should have the proper documentation, and that should include the patient's tobacco status, verification of a counseling intervention, which we're going to talk about the 5 A's, how much time you spent with the patient, and that the chart is signed off or locked. So depending on the insurance carrier will depend on how often they'll pay this code. CMS allows for 2 attempts of 4 sessions each, for a total of 8 face-to-face counseling sessions in a 12-month time period. And obviously, the patient must be a tobacco user with or without symptoms. They must be alert and competent at the time of counseling, and the services must be furnished by a qualified healthcare provider. So using the 5 A's is a good way to make sure that you're capturing everything you need for documentation. So the first A is ask. Ask the patient about his or her smoking status, and that should be documented in the medical record, which if you are doing meaningful use, this is something that you've already been capturing. The second A is advise. Provide clear, strong advice to quit with messaging about the impact of smoking. Assess is assessing whether your patient is ready to quit or not. Ask your patient if they're willing to make an attempt to quit. If they're not ready to quit, then we would move to a type of motivational interviewing to find out, maybe why they're not ready to quit. The fourth A is assist. So you want to suggest and encourage the use of problem-solving methods and skills for cessation. You could also, resources such as the Michigan Tobacco Quit Line could be something that you refer them to, or discuss medication. And then the last A is arrange. This is arranging for a follow-up, either an in-office visit or a telephone call. So that could be something as simple as a call will be placed to the patient 1 week after the appointment to see if they have been in contact with the quit line, if that's the type of resource you choose to use. So your patients who are not ready to quit, there are the 5 R's, and so you want to help the individual identify why quitting tobacco is relevant to him or her, encourage the patient to verbalize negative outcomes of tobacco use, help the individual identify the possible benefits of quitting tobacco use, help them to identify obstacles to quitting, and you can also include anything that they've learned from their past quit attempts. And repetition. It might take more than one brief intervention before a tobacco user becomes ready to quit, and so you should use the 5 A's at every visit until the patient says, yes, I'm ready to make this decision to quit, and let's work together. So just a case study, just to kind of get the feel for how this works. Your 50-year-old male patient presents with a chronic cough. He is a current smoker. Dr. M spent 5 minutes with the patient discussing smoking cessation, and all documentation is in the chart, including how long the conversation lasted. So for this patient, you would use your E&M code, which, in this example, we use the 99213, but the modifier 25 to indicate that we have a separate reimbursable service, the CPT code 99406, meaning that the counseling session was between 3 and 10 minutes. And then your ICD-10 codes, the Z87.891, indicating they have a personal history of nicotine use. And then for this example, I used J44.9 for the chronic asthmatic bronchitis. So it's important to add the modifier, or else you won't be paid as a separate service. The second case study is on a Medicare beneficiary. So 70-year-old female presents from medication refill. She is a current smoker but has no symptoms of adverse tobacco effects such as a cough. So Dr. M spends 10 minutes discussing smoking cessation with the patient. So you would use the E&M as a 99212 or whatever the doctor deems necessary with the modifier 25. You would use the HCPCS code G0436 because the session lasted between 3 and 10 minutes and the patient has no symptoms or they are asymptomatic. And then your ICD-10 would be that the patient has nicotine dependent, whichever code you prefer to use for that. I just wanted to go over some resources that can be utilized in the practice in addition to the coding for billing. There's the Michigan Tobacco Quit Line. It's provided by National Jewish Health and is administered by the Michigan Department of Health and Human Service. It's a free service offered to Michigan residents and tailored to their needs. The quit line will call your patient, and based on their insurance benefits, will help them to determine if they are able to utilize phone sessions or have resources mailed to them, if they qualify for free nicotine replacement therapy. And the service is also web or telephone based. So even after the patient is enrolled with the quit line, there's opportunities for them to do like a texting program with the coaches to help with cessation, or there's a website that has resources, and you can chat with the coaches there. And actually, MPRO is doing a pilot program with the quit line and practices that are interested. And MPRO will come out to your practice and do a staff training to get your staff used to referring to the quit line. And we have resources for the patients so that they know the phone number, so they're not concerned when they get a 1-800 number on their cell phones. The quit line actually will call your patient 3 times before they, say that they're unreachable. So as a free service, definitely something that can be well utilized. The second program is the Michigan Match Program, Managing Asthma Through Case Management in Homes. And we did have some information on this program in the March newsletter. Their website has a lot of great resources for developing action plans for your patients with asthma, and because cigarette smoke can be a trigger for asthma as well as secondhand smoke. So they can also, if your patients qualify for this program, they can also get resources in addition for helping them to quit smoking. And this program is actually for children and adults, based on the different locations that it's offered. The last thing is the lung cancer screening options. For your patients who are smokers, a chest X-ray is no longer recommended for screening. They either recommend the low-dose spiral CT scan or the LDCT. Studies show is the only screening tool that reduces the risk of dying from lung cancer. Medicare is currently paying for this screening, and it's recommended for patients between the ages of 55 and 80 who have a 30-pack year smoking history and currently smoke or have quit within the past 15 years. If you want more information on lung cancer screening and locations where it's available, please contact me, and I'll put my email address in the chat box. And that was a very quick webinar today. So does anybody have any questions?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Melissa, I'm waiting for questions to join the queue. Our first question is going to come from Martha Little. Please go ahead.
Thank you. This seems as though it's a new service in terms of indigent residents having resources for funding a program like this, like there are residents in a nursing home that would benefit from this program, but we've been told that there are no payments provided for smoking cessation.
There is no payments provided for smoking cessation in patients in the nursing home?
Yes.
Okay. I will have to, is that for Medicare has said that to you?
Well, actually, they haven't said it to me directly, just when I've inquired, like to doctors and pharmacists.
Okay. Let me look into that a little bit more.
Okay.
And you said your name was Martha?
Yes.
Okay. Okay, I can look into that for you, and I will get back to you on that.
Okay, will you be emailing or call or what?
Which do you prefer?
It doesn't matter.
Okay, I can email you, and I have your email address from when you registered for this session.
Great. Okay, I'll be looking out for that.
Okay.
Thank you.
Again, ladies and gentlemen, if you have any questions, please press the number 1 key. If you have any questions at this time, please press the number 1 key. Melissa, there are no questions. Oh, our next question comes from Linda Caldwell. Please go ahead.
Hi, Melissa. I'm just interested in getting your contact information, maybe to do some education for our practices on the quit line.
Yeah, definitely. I can, I have your email address, Linda. I can send some information to you, okay?
All right, wonderful. Thank you.
Yep.
Again, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Melissa, I don't have any callers in queue at this time.
Okay. I just wanted to take a minute to talk a little bit more about the QuitLine pilot program. So MPRO worked in conjunction with the Michigan Oncology Quality Consortium. They originally developed this program to be used with oncologists in the QuitLine because the studies show that patients receiving chemo will do better if they're not also current smokers. So the program that we're utilizing is modeled off of that, and MPRO staff will set up sessions at your practice. It's about an hour. We ask for, an office manager, if there's a physician champion, and staff. And really this program is about having everyone in the practice feel comfortable with making that referral. And it doesn't need to all rest on the provider, but when the MA or nurse brings the patient in and asks their smoking status, if the patient says they're a smoker, are you ready to quit? Yes, okay, here's some information about the quit line, and kind of give them the resources that they need to help the patient. So then by the time the doctor comes in, the patient is, more amenable because they've gotten some stuff to look at. And then MPRO will help you to track that in your practice to see if it's you're improving in your rates of referral. And we have put together a nice guide to help, and then even going over who in the office should do what and where it should be documented. So if anyone else is interested in getting that information, please let me know. And if for some reason you're not utilizing an electronic health record, this program can still be used by monitoring progress just manually on paper. So just wanted to give a little bit more detail on that. And then if you can check the line one more time for questions.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And I'm waiting for callers to join the queue.
And if we can please put up the evaluation.
And there are no questions in queue at this time.
Well, I want to thank everyone for joining us today. A full recording of this webinar will be on our YouTube page at youtube.com/mproqio within the next week. We have some webinars coming up May 17th at noon, Getting Your Patient on the Path, an overview of the Stanford DSMP in Michigan. May 18th at noon, tips for utilizing preventive services. And May 25th at noon, adult immunizations in Michigan, using the standards to increase coverage. Again, I want to thank you for joining us today. I will be in touch with both Martha and Linda. And I want to thank you and have a good rest of your day. And if you could please complete the evaluation before you disconnect.
Ladies and gentlemen, this completes your conference call. You may all disconnect and have a great day.